We're going to now demonstrate examination of the ankle. It's important to distinguish between the maneuvers that you do to examine an acutely injured ankle versus a patient with chronic ankle pain. I'm going to demonstrate first what we do to examine the acutely injured ankle. Start first by inspecting the ankle, and we'll demonstrate first the structures on the medial side of the ankle that you want to check. You want to palpate over the navicular, you want to palpate the calcaneus as well as the Achilles. You want to palpate the metatarsal heads. As you look at the lateral aspect of the ankle, you want to palpate the peroneus brevis and peroneus longus as they come around the lateral malleolus. You want to palpate the distal fibula, and again you want to palpate the metatarsal heads, particularly the base of the fifth metatarsal, where the peroneus brevis attaches, and with an inversion injury to the ankle, it's very common to get an avulsion fracture at that point. With the acutely injured ankle, it's also possible to get the so-called high ankle sprain. This is an injury to either the syndesmotic membrane that holds the tibia and the fibula together, or of the anterior tibiofibular or posterior tibiofibular ligaments. To examine for a high ankle sprain, you first have the patient stand, and if they can't bear weight, that would be suggestive of a sprain. Other maneuvers that you can do are the so-called squeeze test, where you squeeze the upper leg, and if they have pain down in the ankle region, that may be a suggestion that there is excessive movement of the fibula. It's also important to palpate the fibula up towards the knee to make sure that there's not a fracture, which can sometimes happen with the so-called high ankle sprain. This is known as a mezzanue fracture. Another maneuver that can be done is the so-called cotton test, where you stabilize the distal tibia, grasp the foot, and you move the foot with a lateral and medial movement. And if there's excessive motion in the ankle joint, one side compared to the other, then that would be a suggestion that there's been damage to the syndesmotic membrane. When examining a patient with an acute ankle injury, it's good to keep in mind the Ottawa ankle rules. These are a set of guidelines that help you determine when you should get an x-ray. If the patient has excessive swelling, has tenderness on the metatarsals, or has tenderness on the posterior aspect of the tibia or the fibula, or cannot bear weight on the ankle, those would be reasons to get an x-ray. With those findings, it's much more likely that there's a fracture. When evaluating somebody with an acute ankle injury, often there's so much swelling that you cannot do ligamentous testing. So with a chronic ankle problem, it's important to look for things like a perineal subluxation or instability of the ankle. And I'll now demonstrate how to do those maneuvers. To check for an anterior drawer, you stabilize the tibia, you grab the calcaneus, and you rock the foot forward. And there is normally a little bit of motion as you do this maneuver, but if you compare one side to the other and see excessive motion or clicking as you do that maneuver, that would be a positive anterior drawer test. To check for the talar tilt test, you bring the feet in, tilting the talus, and you're looking for excessive motion one side to the other. This would demonstrate a tear of the calcaneofibular ligament. The anterior drawer test demonstrates a tear to the anterior talofibular ligament. To check for perineal subluxation, you bring the foot into inversion and then ask the patient to try and move against the force of your hand so that they would be everting the foot. If there's a tear to the retinaculum, which is located here, the perineal tendons will sublux over the lateral malleolus and snap back and forth as you do that maneuver.